Okay, so dark, elongated, tightly packed, clustered, so they change their morphology, they change their structure. Okay, and these cells which are present, they are forming a zone, an area, and that area in your distal tubule is called macula densa. What do you call it? Macula densa is a nukta, a spot. Macula means spot, nukta. Okay, and densa means dark. So macula densa literally means a dark spot. Okay, so there's a dark area or a dark spot in the distal tubule where, when it is passing and touching the angle between afferent and efferent arteriole. Okay, that area is very special. We'll talk about that. Okay, so now you see macula densa. Is it a part of the distal tubule or afferent arteriole or efferent arteriole or glomerulus? If I give you a choice. Okay, so macula densa lies within the distal tubule. Agreed? Look at the angle again, and now you look at the afferent and efferent arterioles. Alright? Afferent and efferent arterioles. And try to see where you are touching the macula densa. What change do you see in the afferent arteriole and the efferent arteriole? Now you see the change in afferent and efferent arteriole.
Surface area.
Yeah. Look at the area which is touching the macula densa. What change do you see in that area? Cells are changed, okay? What change do you see in the cells?
Size.
Okay. There are cuboidal type, square type of cells or rounded type of cells are there. And if you go away from that area, the cells are flattened cells, isn't it? Do you see? These flattened cells are changing all of a sudden into big, larger or squarish cells. Cuboidal type of cells. Okay? Well, those cells which are elongated, present at the side, what are those cells? I am talking about the cells which are here. These are the flat cells, right?
Yes.
And now they change. These are the flat cells and now they change. So this area of touching shows a change. I am asking about these cells in general, okay? It will not give you a very good idea, but we need a concept. These cells and these cells, yeah. Smooth muscles, I am hearing one word. What else? What could be other choice? Epithelial. But endothelial. But see, inside the lumen, you have flat cells module. I think endothelial cells will be there inside, right? We are out of the lumen. Okay? The wall, it's wall actually. Epithelium. But see, for the blood vessel, we don't use the term epithelium. Do we use the term epithelium for the blood vessel? No. Okay? So, no, this is not a correct term. What else? Pericytes, outside, because they look like outside cells. But imagine if it is in the wall, if they are module in the wall, if it is the wall, then what is your choice? Muscle. Okay? Abdul Rahim is saying muscles. Do you agree with him? Which muscles, Abdul Rahim? Yes, they are smooth muscles. Okay? Not very properly shown, but they are smooth muscles, please. So what happens? Normal smooth muscles, when they come and they touch this area, what do they do? In this area, what happens to them? They change. They modify. They modify and turn into new type of cells. Now they are no more smooth muscles. They are cuboidal type of cells. They are secretory type of cells. They are granulated cells. The granules are present. The secretions will be coming. The enzyme will be stored in these cells. And these cells are very, very close to the area of the glomerulus, because they are very qareeb to glomerulus, isn't it? So if they are very close to glomerulus, almost touching the glomerulus, what should I call these cells as? Juxta. So now you know the reason why are we calling these special cells. They are coming from smooth muscles, but they are modified smooth muscles, please, okay? Alright? They are not contractile. Khalas, gone. Change now. Change is secretion. They are sensitive cells, they receive signals and they secrete. Okay? So these cells are the JG cells. Okay? If I ask you, where do you find the JG cells, what will be your answer? Where do you find the JG cells, my dear? Where do you find the JG cells, please?
Down below
Where exactly? Where exactly? Yeah.
where they touch this.
Okay, that's good. So, JG cells, you will give me a complete answer. Okay, they are in the angle, but in the angle, macula densa is also present. I want the complete answer. JG cells, where are they found? JG cells? In the afferent and the efferent artery. Mainly in the afferent and few in the efferent also. Mainly in the afferent artery and few in the efferent. The main issue is afferent, please. Okay? Major amount in the afferent, some in the efferent also. They are more important in the afferent. Alright? Okay? They will work on the afferent. So keep it in mind. So, now you have learned two new types of cells. One type is called, okay, and the second type is called juxtaglomerular cells. Okay? If you combine these two cells, it will become juxtaglomerular complex or juxtaglomerular apparatus. Okay? So JG apparatus has two parts. One part is called macula densa. The second part is JG cells. Now you clearly distinguish where is macula densa module and where are JG cells module. If JG cells are module in afferent and efferent, you must determine which area is more important for the JG cells, afferent or efferent, and the answer is afferent. Okay? Alright. Please, that's a very, very important. The macula densa cells are touching the JG cells. Do you see that? Physically, anatomically, they are touching. So it means the signals can be transmitted from the macula densa cells. The message can go into the JG cell. Okay? Alright. We are now talking about the macula densa feedback mechanism. Macula densa, if you have understood, now we will work on the mechanism. Please. I am giving you a flow of information. Okay? Just try to catch that information and connect it with your previous information which you have. Now, and you will keep on giving me the answers as I am asking the question. Okay? But try to be interactive, all of you please. Okay? We are trying to control the GFR. We are trying to regulate the GFR. And we are working for the tubuloglomerular feedback mechanism. This mechanism has how many parts? Two parts, afferent and efferent. Okay? We'll see how. We'll begin with the first part, the afferent arteriolar vasodilator feedback mechanism. Remember that? Yes. Afferent arteriolar vasodilator feedback mechanism. Okay? Now, we begin the story, please. The blood pressure in the system, generally in the body, falls to a lower value. Okay? Due to some reason. This will cause a decreased blood pressure in the renal artery and the renal vessels also. What will happen to the blood pressure in the afferent arteriole? Decreased. If the afferent arteriole blood pressure is less coming from the system, generally decreased, what will happen to the glomerular capillary pressure? Its value is decreased. If the GCP is decreased, what will happen to the GFR? Decreased. Okay, hold on. If the GFR is decreased, what will happen to the amount of filtrate which is formed per minute? It is decreased. So the quantity of the filtrate which is going into your tubules, passing in tubules, will it be more or less? Yes. Okay. When you have a less quantity in flowing in a system, in the pipe system, okay, quantity is less. Will it flow slowly or will it flow quickly? What do you think? Slowly, because it's coming with less pressure and less volume, so it will flow slowly. If it is flowing slowly, okay, and the reabsorption is also occurring from that little fluid, sodium, potassium, calcium, ions, substances, they are reabsorbing, getting reabsorbed, okay. Are you giving more time for reabsorption or less time for reabsorption? More time. If you are giving more time for reabsorption, will there be more reabsorption or less reabsorption? Good. Okay. So, more than normal reabsorption. So, think about sodium maybe, sodium and chloride. What will happen to the absorption of the sodium and chloride in the proximal tubule? Same, increase or decrease? Increase. If the sodium is removed more, what will happen to the sodium amount or concentration which is passing into the loop of Henle or passing to the distal tubule? Decrease. Are you agreeing? More sodium is reabsorbed and now less sodium, remaining sodium is now passing into the loop of Henle and then into the distal tubule. Now you are reaching the macula densa. Macula densa will receive more sodium or less sodium? Okay. No, again. More sodium is reabsorbed in the proximal tubule. Okay? Now little amount of sodium is now passing into loop of Henle. From loop of Henle, now it will pass into the distal tubule. So the little amount of sodium is passing into the distal tubule. Macula densa is modued in the distal tubule. Macula densa will receive less sodium or more sodium? Less. Okay? Now this less sodium is a stimulus for macula densa. Macula densa is a sensor area and it checks the sodium, normal sodium coming or not coming. If low sodium is coming, alarm really, okay? It is alarmed and it is stimulated. So macula densa cells will be stimulated. It's a special sensory region or a sensor region. Did you get that? Okay? If the macula densa is stimulated, macula densa will send some special signals to juxta. Alright, okay, one situation. Juxtaglomerular cells. Alright, one more. Okay? Look to this. Alright? At the same time, the signals will also go to the smooth muscles which are present. Okay? The signals will go to the smooth muscles and the signals will go to the juxtaglomerular cells. Okay? These macula densa can send signals to both areas, normal smooth muscle cells and the modified cells, yani JG cells. Okay? Now, if the signals, now take one side, if the signals are going to the normal smooth muscle cells and these signals are causing relaxation of the smooth muscle, okay, result is relaxation. What will happen to the afferent arteriolar size and diameter? Dilated. So increase. If it is increased, what will happen to the blood flow which is coming into increase? If the blood flow is coming, what will happen to the GFR? Increase. So Awal, the story begins with the low GFR or high GFR? Low. So from the low GFR, you are tracing and you are coming back to macula densa and sending signals to the afferent arteriolar muscles and they are relaxing and more blood will flow and the GFR again, the low GFR will try to come back to normal value. Okay? So this is a feedback or no feedback? What do you think?
Feedback.
It's a feedback. Negative or positive?
Negative.
Because you are coming back to normal. So you are improving the GFR by the mechanism. What should be the name of the mechanism? The whole mechanism name. Afferent arteriolar vasodilator feedback mechanism. Does it satisfy what we have discussed? All the features are modued. It's working on the afferent arteriole. Vasodilation is happening and by the feedback. So it's an afferent arteriolar vasodilator feedback mechanism. What is the net result of this mechanism? The GFR increases and back to normal value. Increase means not going high. Increase means from a decreased value it is coming to the normal value. Did you get that? Great. Okay. Is this part clear? Yes, dear.
Can you repeat?
Yeah, sure. Low blood pressure. Okay. Low blood pressure in the afferent arterioles, low pressure in the glomerular capillaries, less GFR. Less GFR means less filtration. Less filtration means, yeah, slow movement of little filtrate in the proximal tubules. Slowly. More reabsorption of sodium and little amount of sodium is now passing to the next stations, yani loop of Henle and the distal tubule. So less sodium is reaching macula densa because over reabsorption happened there in the proximal tubule. So little sodium is modular now. This little sodium will stimulate macula densa, give signal. Macula densa will stimulate the afferent arteriole, okay? Where smooth muscles of the afferent arteriole, they will relax. If the smooth muscles relax, what will happen? The vasodilation will happen. Vasodilation will increase the blood flow in the glomerulus. Increased glomerular blood flow, yani GFR will increase and it increases back to the normal value, taqreeban. Okay, so this is a feedback mechanism. Did you get that? No problem in this one? Look at again the same story. Now please be careful. The story is kind of similar. Okay, we are quickly finishing the story. Same story is repeated. From the beginning, low blood pressure and everything is happening till macula densa. So what happens? Low sodium is reaching macula densa. Now I am changing the site from this. Okay, macula densa is now stimulating the JG cells. Actually, macula densa is a common station. It can do two things. Owl, it can stimulate the smooth muscles and it can stimulate the JG cells. Huh? First we talked about the smooth muscles and the afferent mechanism. Now we are talking about the JG cells and the efferent mechanism. Okay? Now macula densa with the low sodium stimulation will send the signals to the JG cells. What is so special about JG cells? They are secretory cells and they are filled with special granules called renin, okay, in the inactive form. Quickly the renin is activated and released into the blood. Look, if these cells are filled with the renin, all these cells are filled with the renin, okay, and you receive stimulation of these cells will release renin into the blood. Blood is passing here, isn't it? Blood is present here in this. So they will release renin into the bloodstream of the afferent arteriole, isn't it? Yes. So renin is passing into the blood. Is renin a hormone or an enzyme, naturally speaking? True sense. Actually, biochemically, what does it do? It's an enzyme. Alright? Hold it. This is a protein breaking enzyme, a proteolytic enzyme. It is now modular in the blood. It means it will do something in the blood. Its action now starts. What does it do in the blood? Alright? Okay. Alright. Blood, please. In the blood vessel. This is, for example, renin. Okay? And it is attacking or working a big protein in the blood. What is that protein, my dear? Angiotensinogen, and inactive form. Very nice. Okay? It's angiotensinogen. Alright. Well, renin is like a knife, a cutting knife. Okay? Alright? Just imagine renin is an enzyme, but it's a cutting enzyme or a knife. Okay? And this angiotensinogen, it's a big cake. Okay? It's a cake. You have a knife and you have a cake. Alright? So obviously, what will knife do to a cake? Well, if you are civilized enough, you will not attack it like this. Okay? What will you do? If I give you a cake and if I give you a knife, I know what you will do. You will make a piece out of it, isn't it? Okay? So you will take a section of your own choice, big or small, but you will take a part of it, isn't it? So this knife will cut a little piece and this piece will come out separately. Alright? This piece is now free in the blood and this piece is called angiotensin 1. Alright? Okay? Angiotensin 1 is now flowing in the blood. Renin has done its job. Halas, renin's role is finished. It has removed angiotensin 1, a small part, only 10 amino acids, only 10. That's why I said it's a small part. It's a big protein and you're cutting a small piece out of it. So what will happen? Angiotensin 1 is small. Now, the whole blood is flowing through your general circulation and now it is passing into the lungs. Do you remember that? Yes. Okay. Now it's passing into the lung capillaries. Okay. Now, in the lung capillaries, for example, if this is a lung capillary, this is a lung capillary, lungs. Okay? And the same thing is coming here. The pieces are coming here. These are angiotensin 1 pieces which are coming here. And this is the endothelium of the capillary. Alright? This is the layer of the capillary cells. Endothelium. This endothelium has very special projecting knife-like pieces. a special enzyme is attached here, just like a knife, a little knife. Okay? And this angiotensin 1 is passing here, and it will come on site and it will try to touch this area like this. When it touches this area, well, obviously this knife will cut a little piece from this one also. Okay? And what will happen? Now you will have this kind of a little smaller piece out of it. You have removed some part of it also. Okay? Now a new thing is formed, and that new thing is known as angiotensin 2. And this special knife-like enzyme which is attached is angiotensin converting enzyme, very famous mashhoor enzyme, ACE, angiotensin converting enzyme. You know that, okay? So now the story is almost finished. You have now a very powerful hormone module in the blood. From renin to angiotensin 1, from angiotensin 1 to angiotensin 2, and finally this is formed. It's an 8 amino acid, octapeptide, and now it's again in the circulation. This blood is again now going to the kidneys, from the renal artery to the whole process, segmental arteries and interlobular and then finally it will go into the afferent arterioles. Okay? When it go into the afferent arteriole, no, I'm not interested. Why? No receptors. Glomerular capillaries, no, not here. Why? Because no receptors. Efferent arterioles, yes, this is the area. I see receptors here, and this angiotensin 2 will attach to the receptors. Okay? What will be the response? Constriction. Okay? If there is constriction, mild to moderate constriction, what will happen to the GFR? First slight increase, and then it is getting back to normal. Yeah, to normal. Remember angiotensin 2, it's normal. This is what you wanted. You wanted to regulate the GFR from the low value to a normal value, and you have achieved it. So you have got two mechanisms now to improve the GFR. Okay? Now tell me, if you compare the afferent and efferent mechanisms, what differences do you find in these mechanisms? Number one, afferent and efferent. Number one. One is operating through vasodilation and other is operating through? Good. What is the other point?
Afferent, faster.
Okay, which one is faster and quicker? Definitely afferent. It will begin first and it's a quick. And efferent will take long time because hormone formation coming back, it will take long time. Good. What is the other difference? Any other?
Type of stimulation.
Which is more powerful? One or two? This first mechanism or the second one? Afferent or efferent? Yeah. First mechanism is quick to start, but it will not be so powerful. Okay. The second mechanism is slow. It will take some time, but it will have a long, tawil effect, sustained effect, isn't it? So more powerful than this one. One more. In the nature of the mechanism, what is the difference? One is hormonal, another is a kind of a direct mechanism working on the smooth muscles or the local mechanism, local structural mechanism, the wall. Okay? And the second mechanism is happening through a hormone system, isn't it? So these are the differences between efferent and afferent. But these mechanisms, the signals start at the same time. Okay? Because their initial part is same. From the macula densa, you have two pathways. The first pathway is quick and the second pathway is slow. But they both help each other to improve the GFR. Did you get that? So together, if you embrace these mechanisms, you will call them tubulo-glomerular feedback mechanisms. Yani afferent and efferent, if you are closing them together in one, it will become tubulo-glomerular feedback. Are we clear about the feedback mechanisms? No confusion about efferent and afferent? Great. Very nice. Okay. Same thing. You will do it yourself because it is written here. I am not, because we have discussed everything in detail. Everything is there. And we are done with this part. Okay? We have done the regulation. So points of regulation. Is auto-regulation more important or the local mechanisms which are there like hormones, autopoietic or sympathetic system? Auto-regulation, okay? Is sympathetic system working all the time or only in special times it is significant? You know the reason, okay? And the mechanism which is controlling the auto-regulation, is it a feedback mechanism or some other mechanism? And which type of feedback? Alright, so you have enclosed everything in your summary and you understand that. At this point of time, I'm giving you a break again to refresh for about 5 to 10 minutes, not more really, because we need to finish